Okay, so I did say hot off the press. In fact, that's a bit of a misnomer because all the results I'm going to present now actually haven't been published, so some of it is going to be shared for the first time. Okay, so the areas that I want to cover is changes in SUDI mortality that's occurred in New Zealand. I want to talk about our safe sleep program. I'm going to provide some very preliminary results from the SUDI nationwide study, and I'm going to talk about the safe sleep calculator. So the first thing is the change in post-neonatal mortality. So post-neonatal mortality is deaths from 28 days through to the first birth date from all causes. So you can't call something else. It's all causes. And so when we started in sort of 1985, we had in New Zealand a post-neonatal mortality rate of 6 per 1,000. When we did our original New Zealand cot death study and found that sleep position was an important issue, and we gave the advice not to sleep on their tummies, you saw this dramatic drop of 2 per 1,000, literally overnight, within a year. And then what seems to be what happened, what we think, is that for the next period of time, there was a gradual decrease in post-neonatal mortality. None of it dramatic, so fluctuating a bit. But we think that this is primarily that the advice got changed from, so the original advice in New Zealand was that babies should be on, avoid being placed on their tummy. So we had advice tummy, side or back, and then we changed it to back or side, and then eventually to back only. And so it was an evolving process. There's been a lot of concerns that over that period, from 2000 onwards to 2010, there's really not been any change. And then over the last 4 or 5 years, there seems to be something happening. So it's gone down further. Can't be guaranteed because you can still put a line from here to here, and it wouldn't, it could just be part of a continuation. But we feel that there's something happening here which we wanted to try and understand a little bit better. What's happened in the last 4 years is there's been a focus on safe sleep, and so we now have a safe sleep day. I'm not putting it on because the size is too big. And so this says back to sleep, safe sleep day, which is actually a bit of December, safe sleep, every sleep. And so there's a big focus now on safe sleep. Now, why? What's the issue here? There's basically a recognition that many of the deaths are either caused or associated with bed sharing when the mother is asleep. Now, I need to qualify that. When I say bed sharing, I mean sleeping on the same surface, so it might be on a mattress, might be on a couch, might be on a single bed, it might be on a king-size bed. It's just the same surface. Mother really means any person. In over 90% of the cases, it's the mother. So for simplicity, I'm using mother. Bed sharing. This is a meta-analysis undertaken by Mimi Veneman. As you can see, there are now loads of studies from our original study back in 1992. There's now been a whole host of studies, and you can see that the increased risk is pretty substantial. Robert Scragg was the first one to show an interaction with smoking, and that's been confirmed both in the Kesdy study, Scotland, and in Germany. What's been less clear is whether there's a risk for infants of mothers who don't smoke, and because that, even though it's an increased risk, it doesn't quite sneak in at the normal statistical level. rather than just dealing with odds ratios, I think these figures are actually much more informative. If you look at SUDI in New Zealand, we did a review of all the deaths, infant deaths referred to the coroner over a 10-year period, and we reviewed the police records, and there were 188 sudden unexpected deaths in infancy. 121 of those deaths occurred while bed sharing. That's 64%. And if you just looked at those infants that were under 1 month of age, bed sharing was implicated in over 90% of the deaths. We looked at alcohol, and that was implicated in 17, in other words, 14% of the deaths, and this data is published. So we have no doubt that bed sharing is a major risk factor for SUDI, especially when other risks are present, such as being preterm, low birth weight, in utero tobacco exposure, alcohol, and young infants. And over 60% of SUDIs are associated or caused by that should be bed sharing. You can't believe how many times I've read that and still missed it. Actually, you probably can, but still. So one of the things which has been fantastic is the Safe Sleep program, and in particular initiated by David Tiffany Leach with the Wahakura. The Wahakura is a plastic basket which provides a safe sleep space for the baby, and this basket can be taken in bed with the parent. The unfortunate thing is it's very attractive, but it's got to be made by a really good weaver. Otherwise it's got floppy sides which actually provide no protection whatsoever. It's also very prickly. Now, Stephanie Cowan developed the Peppy Pod, which is basically a plastic box with a bit of cloth around it and a fitting mattress. This is actually a lot cheaper option than the Wahakura. And she actually initiated this following the earthquakes in Christchurch, when there was huge disruptions. Everyone had to, so many people had to leave their homes. They couldn't take their cot with them. They had to go and stay with relatives, etc. And there was no safe place for it. So she introduced this plastic box in response to that. And it's really caught on. The great thing about what's happening in New Zealand, and we have a consistent message: safe sleep, every sleep. And everyone is advised to avoid bed sharing. And the advice is, if you want to bed share, use a Wahakura or a Peppy Pod. So it's a very simple message. In New Zealand, we're no longer in the debate about whether you should target at-risk group, Maori group, smokers, whatever. And that for Europeans that got no other risk factors, it's okay to bed share. Okay, so that consistent message has really taken the heat out of this area, which was controversial at one stage. However, having said that, these Peppy Pods and Wahakuras are expensive in a global sense. And so they are tending to be distributed to high-risk families, e.g. mothers who are Maori, low socio-economic groups, smokers, where the risk factors are. The mothers and the wider family members are provided education as well. And what we've estimated is that coverage is approximately 5% of all live births in the DHBs that supply them. And not all the DHBs are supplying them. We estimate that we should probably be distributing about 20%. So what impact has this had? So I want to look at what's happened with knowledge, what's happened with behaviour, and what's happened with mortality. So the first thing, we've done two surveys, one in 2005, one in 2018, and we just asked open-ended question, and then they were subsequently coded. What factors do you know that increases the risk of SIDS? And so the mothers avoid bed sharing went from 46% to 62%. Sleep in the same room as parent went from 1.4%, no one mentioned that in 2005, to 23%. And then we asked, what did they do? And so sleep position on the back increased from 64.8% to 72.7%. Own bed in the parent's bedroom. Own bed in the parent's bedroom. So this is really a combination of both of avoiding bed sharing and having the baby in the parent's bedroom. Went from just about 40% to 61%. Shared bed in parental bed in parent's bedroom went from 15.3 down to 8.3%. So all moving in the right direction. And this is what's happened. Now, this is post-neonatal, so it's all cause, so we're not just calling it something different. Top line is Maori, and this is the European. Look what happened here. Dropped. And 2014 has also dropped as well in Maori. And this must be unique to have a program that beneficially affected our most deprived group. And when we looked at it by DHBs, then those are our district health boards, this is the group that isn't issuing them, and this is the group that is issuing them, and again they've had the drop. Now, it's not a randomised controlled study, it's just observational, but it seems to me quite convincing. So, knowledge of risk factors for SUDI has increased. Prevalence of recommended infant care practices has increased. Post-neonatal mortality has decreased, especially in Maori and DHBs that have a focus on education and Pepipod and Waikura distribution. Pretty cool. So what we've concluded, I think New Zealand's shown that post-neonatal mortality and by inferent SUDI mortality can be reduced further. Sleep spaces, that's the Waikura or Pepipod, provide a focus. This has been accompanied by education of health professionals. All the health professionals are now talking the same language, and their families, and this is an option that others may wish to continue. My challenge here is that the Pepipods are being provided by charities and not by the DHBs, and so trusts and things will provide funding for a few hundred, and then you go back to them because there's a whole new group of babies. It's damn difficult to maintain the program. Right, move on to the next bit. The SUDI nationwide study, and I'm showing you some preliminary results, and they are really preliminary, and I will say that we're still looking at some of the definitions and things, so there may be slight changes in the numbers, but I'm sure that the numbers are robust, that the conclusions are robust. So the first thing is, why did we do a new study? After all, it's all been done. Well, what we felt was that when you look at the figures in New Zealand, and so you looked over a 5-year period, and you look at the number of deaths, 62% are Maori. Look at this high rate in Maori, Pacific high. We really can learn from Asian. So, firstly, we've still got this very high disparity, or at least when we planned the study. 50% of the deaths were occurring in a co-sleeping context. There was a complete lack of information on individual SUDI cases, and the estimation of the prevalence of the risk factors in the community are actually based on very small surveys that Lynn Hutchinson and I have done in Auckland. So we haven't got a feel for what's actually happening over the whole country. So we did a case control study. We covered the whole of New Zealand. We had a 36-month collection period with those dates. We had all the SUDI deaths that were referred to the coroner are eligible for inclusion in the study. The initial assessment by a trained health professional, which we referred to as SUDI liaison, was done under the auspices of the coroner. And the coroner owned the data. And that was so important because we actually managed to get in and didn't have battles with the police, because the police would just be overruled by the coroner. In that initial assessment, we'd also do a death scene investigation and dole reconstruction. We would then do a research interview with informed consent, which was undertaken subsequently or at the same time if the families were happy. The controls were group matched, and so they were born in the obstetric hospital ethnicity and were allocated an age. The parents were intervened, and we did the same sleep investigation, same dole reconstruction as that we did with the cases. We estimated the sample size would be 210 cases, and because we were using a 2-to-1, we would have had 420 controls. And we had, over that period of 3 years, we had 305 cases referred to the coroner, 155 were considered to be SUDI and were therefore included, and 140, 90%, were interviewed. Some families just refused to be interviewed by the police or by anyone, that type of person. So, that was fantastic. The coroners and pathologists loved the data that the SUDI liaison staff were producing. For the controls, we actually selected 649, but we could only interview that number. The controls were high-risk group, and it was incredibly frustrating. If you go into the sort of poor areas of South Auckland, which is where a lot of the cases were occurring, therefore we were recruiting from there, they didn't want to know us. The other thing you'll notice is the number of cases were less than that predicted, and that's because SUDI mortality, as I've explained, has decreased. So anyway, look, here's key findings. Sleep position. On the front, small numbers, still in this group, 4.6% were on their front, 8% of cases, odds ratio 3.4. These are adjusted figures. Side, again, about 2, not quite reaching statistical significance, but that's absolutely bang in line with all the other studies. Maternal smoking, 17% of controls, 46% of cases. Odds ratio of, again, 4.9, very similar to other studies. Must have hit 2 buttons at once. Room sharing, 31% of the controls were not room sharing, compared with 45% of cases. Odds ratio 2.5. Bed sharing, 17% of controls, and again 50% of the cases were dying in bed with a parent, and the odds ratio is 4.9. Now we've got to do a lot more analyses to work out all the subgroups and things, and that will come. The strength of the study is that 90% of the cases were interviewed. Limitations are we deliberately selected high risk controls, but this resulted in only 40% of controls seen, which raises the possibility of selection bias. However, the controls that were seen are high risk, so 52% of the controls were Maori, 35% smoked, and 8% said that they drank alcohol in the previous 24 hours. So this is a high risk group. So there are many more studies, many more factors which that we've collected, which still needs to be examined. But what we can say is that our preliminary findings indicate that the risk factors identified in the original study and in subsequent studies are still relevant today. This implies that our current SUDI prevention messages are still appropriate, at least in 2015. And I just want to acknowledge the very big study team. And we had a steering group which met by teleconference once a month. And the fantastic thing was that the chief coroner was so behind this, he attended every teleconference. And his staff, Jackie Andrews was part of his staff, he had a coroner, he had the operations manager, all attending the teleconference. So it got real good buy-in from the group. Now, the last thing I want to talk about is the SUDI risk calculator, or what we prefer to call it now is safe sleep calculator, making it into a positive light. And so what this does is calculates the absolute risk of a death at an individual level. So this is based on Bob Carpenter's work. And so in this paper, Bob put together 5 major SUDI or SIDS case control studies, which had over 1,400 control infants and over 4,500. Sorry, did I say that wrong? Over 1,400 cases and over 4,500, thank you, controls. So it's a huge study to have individual level data. And so from that, he was able to calculate risk for everything, adjusted risks. And then, as you know, risks multiply together. So for example, if you've got a baby that's a low birth weight, 2,149 grams, bottle fed, mother's age 21, there's one previous child, then you can say, well, birth weight increases the risk by 4.2, bottle feeding increases the risk by 1.5, maternal age at 21 increases the risk by 3-fold, one previous trial increases the risk of by 2.3, and so for that particular baby, he or she has a 43.5-fold increased risk of SUDI compared with a baby that's over 3.5 kilograms, as breastfed, mother's over 30 and no previous child. Now the problem is, you can do those sums pretty simple, but then you look at bed sharing, and there's a two-way interaction. This gives the risk from bed sharing by age along here and by smoking. So if you look at non-smokers, the risk is at 2 weeks of age is about 9. So bed sharing increases the risk for infants of non-smoking mothers by 9-fold. But it drops off quite quickly. And so by the time you get down to almost 4 months, there's no increased risk for infants and non-smokers. When you look at smoking, you get even well, they're almost ridiculous numbers. At 2 weeks, you've got an increased risk of 70-fold. And you remember that I showed you data showing that in the first month of life, 90% of the deaths are occurring in a bed-sharing situation. It's because of this very high odds ratio. And so this is the smokers, and it decreases, but even at 6 months, it's still high. Now, you can... now, what Bob's done is provided me with the maths behind it in an Excel spreadsheet, and then we've developed this into an app, and you can go and download the app from this website. So what I'd like to do, I can put it back up at the end for those that want to, but what I would like to show you is what the app looks like. So here's a low-risk family. So it's just one screen on an iPad. So this baby is female, is 17 weeks of age, is 3,500 grams, is breastfed, isn't a twin, is European, shares the parent bedroom but doesn't share the parental bed, sleeps on the back, mother's age 30, no previous births, mother's living with a partner, she's a non-smoker, her partner's non-smoker, she doesn't take alcohol, and she doesn't use recreational drugs. Perfect family, right? And so the risk for this child is 0.02 per 1,000. So 1 in 53,000. Bloody good. Now if you add change it to, and I'm just going to change 3 variables here. I'm going to add young maternal age, smoking and bed sharing. So again, the baby's female, 17 weeks, same birth weight, breastfed, not a twin, still European, shares the parental bedroom, but is bed sharing. On the back, mother's aged 18, no previous births, living with partner, mum smokes, dad smokes, no alcohol and no recreational drugs. And I can tell you, if you start having alcohol and recreational drugs, the risk goes through the roof. But here, you suddenly go from 0.02 to 2.31. Phenomenal increase. And so on this app, it will tell you a number of avoidable factors and also indicates what they are. Now, where are we going with this? Well, I ended up thinking, well, this might be quite useful for needs assessment by health professionals. So, to be able to calculate which families need to have a PEPI-pod. You can actually calculate what the risk. We thought it would be useful for education of families, preferably with guidance by a health professional. The white middle class families are quite happy to do it themselves, but they're not the real risk group. The thing which has been striking is the education with the families is that you can play a what-if game. You can say, if you don't bed share, look what happens to your risk. It can drop by this amount. If you are able to give up smoking, your risk would go down by this much. Actually, I'm not sure it will, because I think the damage has been done, but that's part of the party line, and I go along with that. And the other thing which has been really striking is it's been a fantastic tool for educating health professionals, because even the people that we think understand all about multiplication of risk factors don't really appreciate just how quickly the numbers can get accelerate out of sight. So our current plans is, well, I'm now working with a GP group, and they've developed the app for the MedTech My Practice patient management system, which is used in 90% of all GPs, and it's going to go to the other. There's one other patient management system that covers the other 9%, and that's being done, another 10%, and that's being done currently. It's been modified. We now call it the Safe Sleep Calculator, which I think is a better term. But it also immediately prints out what the risks were if the risks were avoided. So it immediately spells out to the practitioner or the health professional that's working with the family where the gain is to be made. Christine McIntosh is a GP, and she's worked with Shirley Tonkin doing a lot of physiological studies over the year, which some of you will know, is piloting in some selected general practices. We've obtained funding from Cure Kids for 2 years to test and evaluate this. We want to evaluate GP acceptance, we want to evaluate family acceptance, and the goal is, if the pilot's successful, we're going to make it a compulsory part of the 6-week check that's done in primary care in New Zealand. It's wonderful working with these groups that can do something like that, just make it compulsory. So what I'd like to just finish with is some of the things we're doing in New Zealand that could be used in Australia. And I think that I want to finish with just a general comment. Philanthropic organisations such as Cure Kids and SIDS and Kids really do have an important role in research and education. And I credit Cure Kids as having saved thousands of lives, and the studies that they're funding in stillbirth that will prevent a similar number. Thank you.
And I must say, I think it's fantastic that the study is being done, because basically there are no new SUDI studies that have been carried out anywhere else in the world after those initial reducing risks and it's been launched. So it's fantastic. We've actually got some new data and we're not going back and reanalysing all the old data.